Okay, so we're doing week 12. This is phalangeal and metacarpal fractures. We'll review the anatomy, splinting principles around the digit fractures. We're going to look at boxer's fractures in particular, fractures all the digits, something called skier's thumb, I think you're familiar with, mallet finger, and then jersey finger. These are the learning objectives for today. Make sure you get these down. Hope to go over these at the end of the lecture. Here's our case for the day, for the lecture. Clark Kent, he's this 28-year-old guy, walks into the clinic with a boxer's fracture, which is a fracture of the 4th and 5th metacarpal on the pinky side of your hand. It is non-displaced and does not require surgery and is considered stable. He reports that it happened on a date with Lois Lane, when she dared him to punch out a wall. Apparently he did not know the Lex Luthor had secretly put kryptonite in his underwear. So Mr. Kent is like, what orthosis would you make? What is your treatment plan? What are some potential complications? And then why did he feel like he had to try to punch out a wall? So anyway, moving on. So the anatomy we look at, this is the metacarpals. Through here, this is kind of a highlight of the metacarpals. Those are the bones that you can't see kind of in the webbing of your hand, those metacarpal bones. There's the middle one. So when we talk about metacarpal fractures, we're talking the 4th and 5th, so kind of on this side of the hand, commonly where people fracture these metacarpal bones. Then we have these phalanges. We have the proximal, middle, and distal. These are the little tufts. We call these little tufts. These little bone formations on the tips, distal phalangeal. We'll talk about how they can get fractured sometimes. So we're going to talk about the metacarpal fractures down in here, proximal fractures in middle and distal. Something to keep in mind with these, your fingers, as you know, kind of all work together because of the way the tendons are kind of lined up. One big muscle belly pulling all those tendons for the flexors and extensors. So we have to kind of think about that when we're splinting. Really hard to isolate digits and joints. They're kind of all going together. We almost have to kind of do them all or nothing kind of thing. All right, so kind of keep going with the anatomy. This is the intrinsics of the hand. These are the ones people kind of forget about. They're really important. These are the lumbricals. This is kind of like the palm side view. They do a lot of flexing the MCP joint. The big flexors of the MP joints are these lumbricals. They consider what they call intrinsics. So these are like kind of the inside muscles on your palm side. These are kind of the intrinsics. They also help out with extension. They help out with both. Gets confusing. And then we have the dorsal and dorsi. These are kind of the back of your hand. These 4 muscles. And they help with abduction. And then the adduction is the palmar and dorsi, again on the palm side. The key takeaway here is just all these layers of muscles on the inside of your hand. And frequently what happens with fractures and injuries to the digits is they get tight. They start to pull in. So your hand starts to pull into, you lose your web space. And I say web space, that's between your thumb and your pointer finger kind of thing. It starts to pull into flexion mode. So you can't open up your hand as well as you used to. That's kind of a common complication, a lot of these kinds of splints, fractures, and kind of the result of the fractures. We have to kind of think about that and be very conscious of that as we kind of rehab these hands from digit fractures. And these are what they call the extrinsics. So these, again, are all the intrinsics of the hand, the lumbricals and dorsi deep inside the hand. Extrinsics on the back side, top back side of the hand. They do a lot with digit extension. Not sure why that says. Oh, so we have these digit extensions. We have digit superficialis. These are flexors. So these are extensions. So these are not as deep in the hand. So the intrinsics deep in the hand, and we have these other ones kind of on the surface of the hand. These big tendons we're talking about. Superficialis and profundus for the flexors, and then the extensors, we just did that quiz on them, EDCs, indices, and the EDM, extradigitae minimi, These are the big extensions on the back side of the hand, and they have the big flexors. So they're more, when they say extrinsics, they're talking more the outside kind of tendons versus those deep muscles inside the hand. Keep going over these fracture terms. We kind of did this last week, just going to review it. Non-displaced, bone is broken and nothing is moved. Usually heal very well. Displaced, things are moved out of anatomical position. Needs to be realigned, needs to be what they call reduced or reduction. They do that either manually or they do that more commonly with surgery, where they put in a plate kind of thing. Comminuted. Multiple fracture lines, kind of like shattered bone, a lot of different fracture lines. Really challenging to heal that. Intra-articular, even more challenging, kind of goes through the joint surface, kind of disrupt the cartilage, joint space, that kind of gliding and range of motion that you need. And then again, non-surgical, we're talking casts or splints. Surgical, we're talking mostly the plating and the pinning. Okay, so the boxer's fracture. Let's say the boxer's fracture, the 5th metacarpal. If you look at your hand, the big knuckle by your pinky, that's the 5th metacarpal. And these boxer fractures usually involved hitting an inanimate object, hitting a wall. People get angry, they punch, hit a wall, and then they fracture their metacarpal, their 5th metacarpal. Here's kind of a view of it. See, it kind of got smashed and twisted in there. Usually they kind of immobilize it, at least 6 weeks. As soon as they surgery, they plate or pin it to kind of reduce it, unstable fracture. So how do we splint that? So talking this again, they get that 5th metacarpal, 4th or 5th. Usually, sometimes they go together. How are we going to splint that? To think about these principles around the digits and the metacarpals when we start getting into splinting of the metacarpals and the digits. Look at good principles when we're splinting. You need to immobilize the joints above and the joint below the fracture. So we go back to our fracture. Here it is, right here. So I would say this is the joint above, this PIP, and this is kind of the joint below, with the carpal bones. So it has to be pretty involved, at a minimum, involved splint. If you allow too much motion in the joint, you're above or below the fracture, this will put force to the fracture line. We're going to impair the healing. This will shift, kind of move things around. We don't want that. We also need to immobilize the adjacent digits. Kind of getting back to what I said about you kind of remove your hand, you try to isolate, especially if you try to like move the middle finger or whatever. The other fingers want to go along with it. And the reason for that is it's like one muscle belly again with all the tendons attached for the flexors and the extensors. So they kind of want to move together. So with that in mind, you just splint just that metacarpal. You think, oh, we're going to mobilize, we're just going to splint the metacarpal, the 5th metacarpal. But every time he moves the hand, he's moving everything else too. Can't really stop that from happening. So that's why we have to kind of make our splint to get the adjacent kind of metacarpals. Reduce the shearing along the fracture line, again, so it doesn't impair the healing of the bone. So we have something like this. You can see it's kind of above and below the joint. It's got the adjacent metacarpal, goes over to the 4th, so it does the 4th and 5th digit together. It's kind of what they call the intrinsic plus position, which is a really popular position for splinting a lot of these hand digits and joints. I'll talk about why they do that in a second. This is a good kind of benchmark for these intrinsic plus. The MP's at 70 to 90 degrees of flexion, and the IP's in extension. Kind of what they call radial gutter. So this intrinsic plus. Remember the intrinsic plus grasp that you had to learn way back in 300? This is kind of the same kind of deal. Why do they like to splint in that? It kind of facilitates a functional grasp coming out of it. Conversely, if you did it like a karate chop, like straight out, your fingers in full extension, MPs in full extension, it's harder to get that grasp back. Get a lot of tightness and potential contractures in a karate chop position, which is totally non-functional. This is more of a functional grasp. Also, because of the physiology of the joints, the MPs recover well if they're better if they're splinted into flexion, and the IPs recover better if they're splinted into extension. If they're splinting them for extensive periods like the 6 to 8 weeks, they're probably going to be in this. So that's generally why they want that. IPs in extension, MPs in flexion, this kind of intrinsic plus kind of position. You can get these principles down pat. You don't necessarily have to memorize every splint so much. You can figure out, I need to do this because of this for this particular kind of injury. Proximal phalangeal phalanx fractures can be a little bit challenging too. This is, you look at your hand, you've got the palm of your hand, all those metacarpals, and you go right up. You look at the pinky, the proximal phalange of the pinky kind of goes from the MC, the knuckle joint, up to that first PIP joint right in there. That finger, the first part of your finger digit, basically. That's what we're talking about. A lot of these accidents are not sports, car accidents, crushing. Walking the dog. If you talk to Andrea Somberger, who helped put all this together, the CHT at Northern Light, she says she just sees constant hand issues when people are walking the dog and bad stuff happens. You see their hands wrapped around a leash, gets jerked, pulled aggressively, abruptly, bingo, you get like a little fracture there. Treatment, conventional, we're mobilizing in the splint. Again, if you look at this one, it's not pure intrinsic plus, but it's kind of more of a functional kind of flexion of the MP again, extension of the IPs, and it's coming across with these proximal phalangeals and the metacarpals. We have to get that adjacent digit immobilized as well. Not so much when we get out to here. When we get up to the PIP and the middle phalangeal and the distal phalangeal, but that first part of the digit in the metacarpals, we want to be splinting the adjacent digit because of the shearing thing we were talking about. Reduce the shearing, facilitate the healing that we want. Middle finger, middle part of the finger, the middle phalanx fractures. Don't have to worry about the adjacent digit so much. This one, it's like it was in here, so they're kind of splinting below and above. You don't have to worry about some of that stuff as much. These are kind of different kinds of reasons. Conventional, you're just getting them into extension with these little gutter splints. Usually 6 weeks will do it for the healing. Same thing with the distal, the very tip. You can just splint the very tip for like 6 weeks. Usually a crush injury or something happens with that. It can be very painful. Tough injuries, these tufts we talked about. Here's a comminated, like a shattered one. Just splinting the tips into that extension for a good 6 to 8 weeks. Okay, so let's kind of look at this. So kind of think about this for a second. I'm asking which digits were fractured. The thumb and all the digits. How would you splint this? Which digits do you have to immobilize, and kind of from which joint to which joint? So it looks like the fractures through 2, 3, 4, and then the thumb, number 1. So this is the proximal phalange of the thumb fractured, and then these metacarpals through there. So how would you splint that? Just take a second, just kind of think about that. So again, we want to be cognizant of the shearing. So you want to get that adjacent digit. I mean, it's pretty much all the way across, except for the pinky. So you want to immobilize that one as well. Below and above the joint. So this joint, you want it to be at least kind of a minimum from here to there, and from here to there for the thumb. So you're talking pretty involved splint. It's probably going to come up the hand as well. I'm probably going to get into intrinsic plus kind of thing. So it's going to be all the way across, and it's going to be as a minimum from here down to here. Digit fracture treatment. This should look really familiar to you, as in pretty much what we did last week. Same kind of deal, same kind of ideas. Because again, we're just talking about these bones healing, and when they're going to heal, you have to start moving them. Usually you start your therapy around 4 weeks, unless it's a pinning kind of thing. Again, edema, going after the edema is the number one enemy. Getting the tendon glides, gentle wrist range of motion, all planes. Again, within pain tolerance, go slow and easy what the person can tolerate. 5 to 6 weeks, start really easy passive range of motion, getting off the orthosis. 7 weeks, off the orthosis, getting to light ADLs. 8 to 12, it's fully healed. You can go right to town with it, with strengthening, with putty, and full use of ADLs. Again, all this is pending doctor okay, getting your orders to kind of cover your butt so you're not getting into any potential problems with that. Common issues, or the common issue that you're seeing a lot with these digit fractures, we kind of talked about it. This kind of goes back to the intrinsics and extrinsics. Again, the intrinsics are those muscles deep in the hands, the lumbricals and the interossi. Extrinsics are those big tendons that are gliding on top of the hands, all the extensors and the flexors. So what happens commonly is tightness, extrinsic or intrinsic. A lot of times it's intrinsic, but sometimes it's extrinsic. You can get scarring, kind of building up along the glides, kind of stiffening it up, so they're losing their extension or they're losing their flexion. So you start to get tightness with the extensors or the flexors, intrinsics or extrinsics. How would you know this? Obviously, it's 8 weeks plus, you're doing all your stuff, still struggling to get full motion back, full flexion or full extension. I think I'm getting some tightness of the intrinsics or extrinsics of the hand. How do I test for that? How do I treat that? This is what comes into the one test we're doing this week, this Bonnell-Littler test. It kind of tells you which direction to stretch the hand. It gives you a good indication of where the problem is, so you can start going after it. This test can be very confusing. I think it gets too confusing if you start overthinking it. A lot of students have a tendency to do, you start to dwell on it, think about it too much, and you start spinning your head. With this, kind of go by what it says. If you go by what it says and kind of get that down, you kind of got it. Don't need to kind of go beyond what it says, I guess is what I'm saying. So this involves passive range of motion. So you're passively ranging the hand. What do you need to do to see if it's extrinsic tightness? When the MCP joint is extended, here it's extended. The EDC was these extensors, extrinsics on the back, they're all on slack. So the PIP cannot flex. But when the PCP is flexed, you flex it down. The PIP cannot flex. Let me just go through that again. So when the MC joint is extended, as in right here, the PIP cannot flex. See if she's trying to flex the proximal interphalangeal joint, which is this joint right here. Here she's able to flex it a little bit. It's a struggle. She's having a hard time doing it. But she can flex it some. So the PIP can flex when it's extended. When the MCP joint is flexed, the EDC is stretched, the PIP joint cannot flex. This will tell you that you have extrinsic tightness, and this is the pattern. The PIP can flex when basically the PIP can flex only when the MC joints are in extension. So think you're in carotid chop. Now I can flex the PIP. If I flex them, I cannot flex the PIP. This is telling you that if you have extrinsic tightness, the outside of the hand is kind of the issue. If it's the opposite, if it's tightness within, when the MC joint is extended, the PIP joints cannot flex. Can't flex them. But when PIG is flexed, they can flex. The intrinsics are on slack. It's kind of just the opposite. We'll go over that extensively to get it down. To address extrinsic tightness, kind of the outside of the hand, a lot of times it's the EDCs that are the issue. You can try making a full fist, the wrist inflection, you can add elbow extension. To address intrinsic tightness, start with the full flex and extend the digits and extend, so like a PNF kind of thing. Heat, joint immobilizing to kind of think about it. So it's intrinsic tightness. Generally speaking, it's tightness within the palm. We want to extend everything. If it's extrinsic tightness, generally speaking, it's the EDCs on the outside of the end. You want to flex everything. All right, so let's get into some other stuff here briefly. We have soft tissue injuries at the skier's thumb, mallet finger, jersey finger. Skier's thumb. I think you may have heard this before. Lateral instability of the joint at the MCP joint due to strain or rupture of the ulnar collateral ligament at the MCP joint. There's the ulnar collateral ligament. It's strained or it's torn right here. Usually it's like an acute force kind of thing. I mean, they call it skier's thumb. Classically, they think about falling on a ski pole, but it happens, a lot of different ways. It's kind of a skier's thumb diagnosis. So here's a good image too of that ulnar collateral ligament. It's tearing there, right there. There it is again. Basically, it's a tear or strain of that UCL. Gamekeeper's thumb. It's more of a kind of a chronic kind of thing through attrition. It's just happening over and over again. Repeated strain over time, not a single acute injury. That's kind of the difference between the two. Painful swelling, grip. You can treat them both the same way with this kind of splint. It's a thumb spica, comes across the metacarpals there. 6 to 8 weeks. It's an acute kind of thing. May involve, a lot of times it does involve surgical repair of UCL. Okay, so now we have mallet finger. It's jamming basically the tips of your finger, and it kind of ruptures those extensors. We used to call this, they also call this like basketball finger or baseball finger. You envision somebody throwing a baseball at you or a softball, and you don't catch it with an open palm, you catch it with your fingers flexed, like with your fingernails, and it just jams the DIP, the tip of your finger. And when it jams that hard, the tip of your finger, you can see this image, see it's jamming here, it rips this extensor tendon, the EDC. You can see what they call this called revulsion. It's pulling bone right off the finger. Ruptures the EDC, results in avulsion of the bony attachment of the extensor terminus, the distal, or only rupture of the tendon. You kind of get this mallet finger, which is the same as the arthritic finger. Different kind of mechanisms, more acute. You can also get a swan to an acute injury as well. So you can get them through arthritis or acute injuries. This is kind of how it presents. They say, oh, I was playing basketball, I jammed my finger, I'm playing basketball, and now it looks like this. DIP flexion, so we're jammed, and then a DIP hyperextension. It's just like the swan neck. How do you treat this? Just get them into extension. The longer it goes, the harder it can be to heal. So if you have somebody that's, it's having these kinds of symptoms, some kind of injury, definitely want to get them in extension as soon as possible. To be pretty rigorous about keeping them into extension for 6 to 8 weeks. You can use these different kinds of splints for, either side is okay, dorsal or volar, just to kind of give their skin a break. Or they can do surgical kind of pinning into extension. So you don't have kind of this the rest of your life. Then we have the jersey finger. It's kind of the opposite. The mallet is the jamming of the DIP. The jersey is the hyper-forced extension of the DIP. You can't flex it. You ripped the tendon here, so it's kind of ripped this profundus, the FDP, through here. Make you dizzy, but if you go back to this image right in the beginning, right here, this is like when they call it a jersey finger. Classically, you're grabbing the jersey, hyperextending your DIP, and ripping that flexor tendon. This is kind of like a mechanism for potential jersey finger issue with this left hand. Hyperextension of the DIP is kind of a way to think about it. All right, let's make it easy again. So here it is. See how he's got a jersey finger with this ring finger. He can't flex that. See how they're all flexing, but he's lost his flexor. It's been ripped or whatever. need to get surgery for that. It's a flexor tendon repair injury. It's one of a common flexor tendon repair injury. We also do them when the flexor tendons are lacerated. That's kind of what we're talking about next week. And this is the kind of splint you're going to be making next week, this dorsal blocking splint. That's for these flexor injuries. And there's a strict protocol about how you can bring it back after that. We'll get into all that next week. It's kind of basically passive flexion and active extension against the limitations of the joint to kind of bring the tendon back after the surgery. Quite involved. All right, so let's go back to Mr. Kent. So what orthosis, what do you make? So I think you just get the classic boxer's fracture. So we're thinking the intrinsic plus kind of thing, getting the adjacent metacarpal in there, mobilizing the joint above and below. Complications, intrinsic, extrinsic tightness. We check that out with the Vanell Littler, and whatever it is, we can stretch it to get that. Try to work on that. That is that. And what splinting principles apply to metacarpal proximal interphalangeal fractures? We just talked about that. You have to splint the adjacent digit. Kind of the bottom line of that. How do you treat a digit fracture? It's the same principle in terms of 4 weeks, going after edema mostly, a little active, and then more and more as you progress through those weeks, as it was with the wrist fracture. There's those bone healing principles. How do you treat a mallet finger, jersey finger? You're talking, with the mallet, you're talking the extension, gutter splints, extending the DIP, jersey finger, talking flexor tendon protocol with a dorsal blocking splint. How do you stretch for intrinsic, extrinsics, and you're kind of flexing and extending the hand depending on what you're trying to get at. Okay, this is coming up. There's a quiz when you come back from Thanksgiving. There'll be a quiz on the lecture questions and the anatomy for that week. Your AOE is due right when you come back to, I believe, Tuesday, yep, when you come back the same day, as well as your hand construction. So you've got a lot of stuff going on. AOE review. So they have the psychosocial interventions, activities versus exercises, adapting. This is kind of things to keep in mind when you're doing your AOE. Well, these are the things that people forget. Definitely go back and resubmit it if you felt like you forgot these or didn't address them fully. Need interventions to go after psychosocial issues. We're not just talking all those orthopedic great stuff that you got out of the treatment boxes. You need to go after psychosocial interventions. Need activities in addition, not so much versus, but activities in addition to the exercises. When I say activities, I'm not talking about just simulating work, what he does for work. I'm talking about activities that he likes to do as exercises to rehab his wrist. Adaptations, adapting what he does. Things he likes to do, how can you adapt those? So you can start doing them sooner as he starts to recover. And it says, address the 2 potential complications. And there are 2 potential complications with that wrist. Make sure you address both of them somehow in that question or in your box somehow. Make sure you have uniformity in your paper. I know everybody likes to do divide and conquer. You're submitting this individually, so make sure the other sections of the paper go together and that they make sense, that somebody didn't kind of just do it really fast and not really fully answer the question, because you're going to be graded on what the other students did for you kind of thing, so make sure you double check that. And let me know if you have any questions for sure. Okay, I guess that's